Hi, my name is Professor Ndubeze Okonkwo. I would like to start this my community service with a brief explanation of what I do because someone called and requested that I do a couple of videos to help his community, particularly my specialty. And it seems he thinks that nephrology is a separate entity from internal medicine. So I am an internist. So before I became a nephrologist, I have to have specialized in internal medicine. And then after specializing in internal medicine, I saw specialized in nephrology. And then subsequently did an ultra specialty in solid organ transplantation, particularly kidney and pancreas transplant. Today I would like to do a short program on kidney transplant because of some ideas that people have at home, thinking that kidney transplant is just a minor procedure, and if you have kidney failure, you get a transplant and then you're fine. While that is true, if you don't understand all the things that are involved in kidney transplant and you get yourself involved in that, you can actually kill yourself. So what is kidney transplant? I will start by reminding you that kidney failure or end-stage renal disease has only one treatment, which is kidney transplantation. Dialysis is a bridge that connects you from the time you develop end-stage renal disease to when the transplant is done. So dialysis is not the treatment for kidney failure. When the kidney fails, it simply means that the two kidneys, that the filters that help the kidneys remove all the toxins from the body, from all that we eat and drink, and the metabolic activities of the body, all the waste generated in the process, the kidneys will have to remove them. And usually, the components that make up the kidney, the basic unit we call nephron, so they have filters. So when those filters are completely damaged, it means that the kidney is practically dead, and you're not going to be able to filter those waste toxins and other associated functions of the kidney will not be performed. Who qualifies for kidney transplant? Anybody whose kidney has failed completely with a definition of end-stage renal disease, meaning the kidney is dead. Or if you have to have a preemptive kidney transplant, meaning we do not need to wait for your kidney to fail completely before you get a transplant done. You have to have a GFR. It's a big name, glomerular filtration rate, simply measuring the ability of the kidney to clear waste from your body. If that number is less than 20, you qualify for kidney transplant. But it has to drop below 10 for you to be declared end-stage renal disease. Therefore, if your GFR drops below 20 or to 20, you can tell you're a nephrologist if you have somebody who is going to donate kidney to you before you get to a GFR of 20. When your GFR is about, say, 25, we start preparing you for dialysis. And if you're going to do hemodialysis, then we have to put the access in your arm, called fistula or graft. If you're going to do peritoneal dialysis, we will start preparing you and training you on how it's done. But for someone who's not going to go on dialysis, who wants to have a preemptive kidney transplant, you start dealing with this once the person develops a stage 4 kidney disease, and without worrying about what stage is stage 4, when your GFR begins to approach somewhere around 30, 35 thereabout, you know that this person is heading to end-stage renal disease. Then you start preparing the person, if the person has a donor, to do a preemptive kidney transplant for countries like Nigeria. But here in the US, you can have a diseased donor transplant done preemptively if you're on the list and you qualify. So once it's determined that a patient has opted for kidney transplant, we have to evaluate that patient to see whether he qualifies. Because you want the transplant doesn't mean you're qualified, because there are many things that are involved. And then we'll think about who your donor is going to be. The process that will bring you and the donor together, whether it's the disease donor or whether it is a living donor, is quite enormous. So we have to do what is called pre-transplant evaluation, in which we evaluate the patient that is going to be the recipient to see whether the person qualifies for the transplant. There are a couple of things that would disqualify the individual, and there are those things that are completely contraindicates the individual for kidney transplant, and some are relative contraindication. So during that evaluation, we look for things like if the patient has diabetes, if the patient has hypertension, if the patient has proteinuria. Of course, if you have a GFR of 30, one expects you to have proteinuria regardless of the cause of your kidney failure. We also look at whether what your blood type is. We deal with immunology, typing your gene. We call it antigen match. So we start by looking at your HLA, which is human leukocyte antigen. And then we start screening you for infections to see whether you have HIV, if you have hepatitis, if you have CMV, which is a form of viral infection, Epstein-Barr virus infection, syphilis, tuberculosis, and etc. Then we worry about if the patient has cancer. So we have to screen you, because certain cancers will disqualify you from transplant. And some will not. If you have the cancer, then you are treated. Then after treatment, a certain number of years are given before the transplant is done in certain cancers. But certain cancers automatically disqualifies you from kidney transplant. We look at the patient to see how big the person is. Obesity, we use the BMI to measure the patient's weight, whether this person qualifies, because as you know, obesity brings on a whole lot of illnesses. So anybody with a BMI that is more than 40 will not be transplanted by many transplant centers in America. Smoking is another thing we look at to see whether the patient smokes, the patient uses drugs, the patient drinks alcohol heavily. And so we can counsel the patient to make sure that this patient is going to be compliant. Because if you are smoking, what smoking does to the blood vessels, if you are destroying your blood vessels, your kidney is not going to do well. There are other things we look at as some genetic typing in certain families. If we see that you have a risk for certain kidney disease, such as, say, FSGS, which is focal segmental glomerular sclerosis, a subtype of it can be screened for, because after the transplant is done, if you have a particular subtype, the kidney is going to fail right away. Particularly people who have APO1 subtype. And then we do your gene typing, the HLA, A, B, and DR. And we are looking at 0 to 6 antigen mismatch. The number of mismatch someone has, this mismatch means somebody who's going to give you the kidney, who is the donor, and the recipient, their genes have to be close to one another. In other words, somewhat compatible. So if you have 4 out of 6, if you have 5 out of 6, if you have 3 out of 6, so how close you match with your donor determines the lifespan of your the graft, which is the kidney that has been donated. When you are receiving a kidney from a dead person, and no, when we say dead person, someone who is almost dead, who has donated his organs, we can use the machine to sustain life in that person so that we can harvest the organs and use, transplant the organ to someone who is going to be the recipient. Because nobody is going to take an organ from a dead person and give to you, because the organ, if somebody is dead, then the organs are all dead, therefore they're not useful. Then we then take your donor, the person who is going to donate that kidney to you. So if it's a living donor, we have to evaluate that individual also. But if it's a deceased donor, somebody who is dying and who has donated the kidney, we have to also evaluate that person and see whether the person has the same kind of infections that would disqualify the recipient. It most likely would disqualify the donor also. So if a donor has HIV, you can't take that HIV kidney and give it to somebody who doesn't have HIV, and that's common sense. However, if somebody has HIV, who is going to be the recipient, we can actually transplant an HIV kidney to that person, because both of them have the disease and they have nothing to lose in that context. If somebody has hepatitis, if it has hepatitis C or hepatitis B, hepatitis C can be eradicated with the new medications now. So if we see an individual who has hepatitis C, and we think that the patient who is the donor is also hepatitis C, we can take that kidney, even if we don't believe he has it, and if he turns out to have it, then after transplantation we can treat the donor and eradicate the hepatitis C virus. So what is involved in kidney transplant is humongous. So we divide the kidney transplantation, and those who donate the kidneys, we divide them into 3. One group we call the diseased donor kidney transplantation, the kidney we are getting from somebody who is almost dead or who is dying. And then we have the living donor kidney transplant for somebody who is alive and well and very healthy, that is willing to let go one of his kidneys that can be donated to whoever he chooses. And then we have what we call commercial kidney transplant that used to be almost around the world. It used to make up to 10% of the transplanted kidneys around the world, until the societies gathered in Istanbul, Turkey, and then there was Istanbul Declaration, because of the abuse that people are deceived and they sell their kidneys to people not knowing the consequences of the surgery that is involved, and etc. So that number has decreased tremendously. Most advanced nations will not allow you to participate in buying or selling the kidneys. It's against the law, particularly in the United States. How long the kidney lives would depend on a lot of things. So on the average, somebody who is on dialysis, the average lifespan for anyone on dialysis is about 9 years. Of course, some people will die within months of starting dialysis. Some people may live up to 30 years, but those are outliers. But majority within the mean are about 9 years. And each time you're on dialysis, every day you're on dialysis, your lifespan continues to decrease. We're going to leave the reason for that for a different time. But once you get transplanted, then your lifespan begins to increase every year that your kidney graft, which is the transplanted kidney, every year is functional. Your lifespan is actually increasing. It goes in the opposite direction. If you're on dialysis, it's going down. If you're transplanted, it's going up. Therefore, everyone is driving to have everyone who has kidney failure to receive a transplant. And if you have a good nephrologist, he will work so hard to make sure you get transplanted if you qualify for transplant and never get on dialysis. And that's the goal of every astute nephrologist. So the diseased kidney transplant on the average will last about 10 years. Of course, there are people who last up to 20, 25, 30. Those are outliers. Majority will be within 10 to 12 years. And then living donor kidneys, its lifespan is about 15 years. I've seen patients with 45 years. I've seen patients with 35 years, 40 years. So that majority is going to be anywhere from 10 to 12 years. And so what is going to determine how long this your kidney survives will have a lot to do with the compliance of the patient and many other factors. If the kidney you received, who gave it to you, what is the age of the patient that gave it to you, what are the other medical problems that patient may have that did not contraindicate the donation. So the type of kidney you receive and who you receive it from, whether you receive it from a child or an adult, is going to determine. So the older the patient is, the less the kidney is going to survive. Because as you know, as you're getting older, your nephrons will be dying gradually. Even if you are very healthy, the natural progression of kidney dysfunction, where you continue to lose your nephrons as you get older. So the older the kidney is, the less viable it's going to be. So there are many things that govern it. So if we choose the right kidney for you, based on your pre-transplant evaluation, both of the donor and the recipient, then you achieve the highest chance of getting a quality kidney that is going to live for expected time. So we use some nomenclature. I won't bother you to spell them out what they mean. We say KDPI and EPTS. These are things we use to make sure we get you the kidney that you need. And we give you all the information necessary so you know what type of kidney you're getting and what is the expected survival of that kidney. In terms of donation, the black people are lacking behind in being living donors. In America here, about 12.3% of blacks donate kidneys compared to 65.1% of the white population in living donor kidney transplant. So now that I have said who qualifies for kidney transplant, what is the benefit of kidney transplant, and the pre-evaluation that leads to both the selection and determination of who qualifies for the transplant, and then dealing with the immunology of the transplant to make sure that you are compatible with the donor. Otherwise, if we give you a kidney that your body is going to reject, you may actually die from that rejection within hours to days or to months of the transplantation. So we have to make sure that you get the kidney that is compatible with you. During the kidney transplant, something that is very important for people to remember is that the medication that we are going to use to overwhelm your body, so that your body that sees the kidney that you're going to receive as a foreigner, anything that comes into your body that is not yours, your body sees it as a foreigner, and its goal is to destroy it. So in so doing, we have to give you certain medications to suppress your body from killing off the kidney that you're going to receive. And we call these medications immunosuppressants, which means they're going to suppress your immune system. And these medications are so powerful that when you receive them, it's going to make you so vulnerable to infections. Therefore, we're going to prepare you to begin to mitigate the circumstance to make sure that you don't get infection. And if you do, that we're there to identify the illness and treat it very quickly to prevent you from dying. We have 4 major medications that we use in our transplant center, one of which is thymoglobulin, and the other one is alemtuzumab. We call it Campath. And then we use a steroid, just a large dose of steroid, and then basilumab. And which patient gets which medicine is usually one of the immunosuppressants with the steroid, which is equally an immunosuppressant, but it's in a different category. So if somebody has diabetes, we try to use a steroid-sparing immunosuppressant, which means we would like to use immunosuppressant for induction, which means the medicine we're going to give you that is going to lower your immune system. We'll try to avoid steroid because steroid makes your blood sugar go up. So a large amount of steroid is going to cause your diabetes to be uncontrolled. And as you know, if you have diabetes, diabetes kills the kidney over time. So we don't want to give you a new kidney while we make your diabetes worse with medication. So in that case, we use a steroid-sparing induction called Campath. But if we use thymoglobulin, then we have to add steroid to it in order to achieve our goal of suppressing your immune system. As you get older, your immune system begins to decrease, so you are unable to fight off infection as you should when you were like 20 years old. So we use bacilimab for older people, especially people who are 60 years and above. So once the medicine is given to you, then the surgeons will, if it's a living transplant donor kidney, the patient will be in one OR, and who is the donor, and the recipient is in a different OR. OR means operating room, where the surgery is done. So a group of surgeons will be in one room harvesting the kidney from the donor, and then a group of surgeons will be preparing the recipient, opening the abdomen and getting to where they're going to place the kidney. So all those pre-transplant evaluations that were made, part of which was to do a CAT scan of the abdomen and pelvis to make sure your blood vessel is open enough where the kidney is going to be attached for you to get the blood flow that he needs. So once that organ is harvested, the kidney is harvested, then they will bring it and transplant it in this individual. And once the transplantation is over, obviously once the patient wakes up, we're going to start giving him medications to take. And we call these medications the same immunosuppressants, but they are taken as pills. Not the heavy one we use initially to suppress the immune system at the beginning of the transplant, but this one is going to help you prevent your body from rejecting that kidney for the rest of the kidney life. And these medications usually one is tacrolimus, another one is cyclosporine, the prednisone, and mycophenolate. And if we choose tacrolimus, each one we choose has its own side effect, and all of them have the same benefit, but side effect is different. So what we choose for one person may be different from the other, but there has to be a combination of what we call the tacrolimus. We can combine that with prednisone and add mycophenolate, or we can use cyclosporine in place of tacrolimus based on the patient population. While at the same time, we are going to give the patients certain medications to prevent certain infections. So we give Bactrim, and the reason for using the Bactrim, the particular infection that we are concerned about, called pneumocystic gyrovesi. In the past, we used to call it a pneumocystic carinii, which can cause you pneumonia and kill the patient. So we start you on Bactrim, which is a form of sulfur antibiotics, to prevent you from getting that infection. We also start you on a medication called ganciclovir, which is going to prevent you from having what we call a cytomegalovirus infection. And we put you on fluconazole and or nystatin, or both. Both of them are antifungal infection medications that will prevent you from having infection from fungus. And there are infections that are of concern to us during transplantation. We work so hard to prevent them from coming, and then if they are there, we have the tools to diagnose them and treat them. These infections, I'm just going to mention a few. So you will see that if you're going to be transplanted and you don't have a good infectious disease specialist, and you don't have a nephrologist that is very astute to know these infections and how to look for them and how to treat them, you kill yourself. So cytomegalovirus, BK polyomavirus, Epstein-Barr virus, hepatitis C virus, hepatitis B virus, HIV, pneumocystic gyrovesi, fungal infections, and urinary tract infections. So those are expected infections at different times after the transplant. So while we make sure you don't have them before we transplant you, we want to make sure you don't get them after transplantation. And sometimes after we evaluate somebody who is going to give it to you, the person may be negative, but after the transplantation, we find out, oh, the patient actually tested falsely negative. So we have to deal with infection. And then once the transplant is done and the patient is taken back to the room where he's going to recover, then the kidney starts working right away. And it's a beautiful thing to see. Urine output is great. And then you have to watch the kidney like a hawk. As soon as you start seeing there is allograft dysfunction, meaning the kidney is beginning not to perform. So you have to, again, as a good transplant nephrologist, you have to find out why. Okay, and you have what we call ATN, acute tubular necrosis, which can happen as a result of multiple factors. If you find that the patient has it, you treat it, and the kidney recovers. You can have problems that comes from the surgery itself, where the blood vessels are connected from the donor kidney to the recipient, and then how the bladder is going to be connected, and there is a stent that they're going to put there, and etc. If you remove the stent, eventually you may have a problem with stenosis, in which the stenosis creates an obstruction and the kidney begins to fail. You have to identify that and treat that also. Your body, regardless of the medicine we are giving you, can start rejecting the kidney. Then if we identify that, sometimes we have to do a kidney biopsy to prove it by looking at the histology to prove that this is rejection. And then we treat it appropriately. And then there's something we call a donor-specific antibody, which is going to become a problem to the patient. We identify that also, and we treat. There are cases where the person who has kidney failure, the type of kidney failure that he has, demands that you let the patient know that the person may, most often than not, have the same disease that killed his kidney resurface in the new kidney. There's something we call IgA nephropathy, membranous nephropathy, or FSGS. Those are known to be recurrent glomerulonephritis. So you look for them and then do your best to treat if they arrive. And then there is a question of delayed graft function. You can put the kidney at the end, it's not working. If an astute nephrologist would know why is the kidney not working? Is the function delayed? And then you keep the person on dialysis until the kidney starts working. But you're going to know the difference between a kidney that has a delayed graft function versus a kidney that is either bad or injured during the transplantation. And then after the transplantation, as you're taking these medications, there are risks of developing cancer while you're taking the medicine. Some of those risks are cancers, post-transplant lymphoproliferative disorders, in which patients will develop cancers like non-Hodgkin lymphoma, or skin cancers like melanoma, Kaposi sarcoma, and other skin cancers like squamous cell cancer and basal cell cancer. So you will see that kidney transplantation requires a team of doctors. You need the surgeons, you need the nephrologists, and in a case where you have kidney pancreas transplant, of course, you're not going to go to a living person to get his pancreas to transplant to somebody. So somebody has diabetes, and a donor is donating all of his organ. So you can take the one kidney from that person and take his pancreas and transplant both of them into one patient who has diabetes. His diabetes will be cured forever. Therefore, his new kidney is not going to be affected by diabetes. So he has a longevity that would have been otherwise shortened by untreated diabetes. As you know, diabetes is #1 cause of kidney failure. So looking at this, this will help you address this trend that is going on in developing nations, particularly a place like Nigeria. Last week, I found out that through the social media, that a woman from Ozobolo, which is in Anambra State, was caught trying to sell 2 of her children, probably about 4 and 3 years old, for 1.8 million naira, which is basically $1,000. For whatever reason, some people attribute it to hunger, other people attribute it to whatever thing they want to, but I attribute it to wickedness, because no amount of hunger will encourage a woman to sell her children. And those who are buying these kits, what are they going to do with them? Part of it is the black market of buying and selling kidneys. And those who are buying the kidneys, they don't know what the disease is or what the antigens that these patients have that you are buying the organ and selling. You don't know the disease that they have. The quality of your physicians who are going to engage in this. If one is already a criminal, you can be rest assured he doesn't have their best interest at heart when he's getting you an organ. It is about money, money. And so something else that compelled me to do this presentation is that somebody that I know has end-stage renal disease and is on dialysis. So I asked to see what the etiology of the kidney failure is, and it turns out to be adult onset polycystic kidney disease, which is autosomal dominant, which means that some of her siblings already have the same illness, and some of her own children already have the same thing, even though it has not manifested yet. So in the real world, if somebody has polycystic kidney disease, we have to screen the person because brain aneurysm is one of the components. So before you transplant this individual, you have to make sure the person doesn't have any aneurysm of the brain. You have to screen the liver for cyst and the entire abdominal organs. You have to look at them from the same standpoint because the polycystic kidney can affect even the colon. So this individual, somebody is asking her to give them 19 million naira and they will transplant her. But she has not discussed about how am I going to afford the immunosuppressants I'm going to take after the transplant? How am I going to find a nephrologist or a transplant center that is going to manage me as a patient, looking for all these complications that will arise because they will be there. It's not maybe or maybe not. But if you don't have someone who is trained to look for these things, you are going to die. So getting the transplant and urinating for 3 or 4 months or living 1 year and then die, you haven't achieved your goal. So it is imperative, it's very important that before you get the transplant, buying and selling kidneys is against the law in many countries. Again, Istanbul Declaration makes it a crime internationally to buy and sell kidneys. So if you find a family member, a friend, a stranger who wants to donate the kidney to you, you should go through the normal process of pre-transplant evaluation in order to get the quality kidney and achieve the goal that you set out to achieve, which is to increase your lifespan and quality of your life by getting a functional kidney. And that functional kidney should either come from a deceased donor or from a living donor instead of commercial donor, because of all these things that I have explained. And then finally, it is important to recognize that if you do not have a transplant center that manages your kidney after transplantation, you will die. No question about that, because there are many infections that I just described. One of them will come and kill you. Or the medicine you are taking, some of them, if the levels are too high and you don't deal with the level because you don't even know, the same medicine that is supposed to save the kidney kills you and kills the kidney. So I discourage people from getting involved in backdoor organ cells and transplantation. It's in nobody's interest. This is a summary of the transplantation of kidney or pancreas. This is not a ground round kind of presentation, which would take about 2 to 3 hours. And if we have to discuss the entire kidney transplantation, immunology alone would take you years to understand all the details that are involved in getting the antigen typing and things you need and don't need. But ultimately, when the kidney starts functioning, all of the functions of the kidney, which you have lost from the end-stage renal disease, starting from the anemia you have, will resolve. All your electrolytes abnormalities will resolve. You can eat what you want. However, because of infections that come from food that can kill you, your transplant center through the dietitian will help you understand to make sure the temperature of the food you are eating and the source of the food you are eating, because germs come from different kinds of food, especially vegetables. So I hope this helps. And if you have any question, you can reach me in my office. This is a community service. Discuss this with your physician, and I hope this helps you.